Yeah. Hello guys, good evening all of you. So first of all, I wish you ki you had a good exam. In Pharmac, most of the questions very simple questions or the moderate type of difficulty, easy to moderate I would say. Not very tough. Second thing I would say is sir, almost every question have been discussed in the classes. So I hope you got 100% strike rate. Now I got some of the questions, so definitely we'll discuss these questions. First of all, please message me if I'm audible, visible, yes or no. And the second thing is, please let me know if there are any changes in the options or any change in the questions. So please let me know, right? Because these are just recall questions, recall MCQs. So I'm not sure 100% about these questions. Is it the same question? So am I audible and visible, guys? I'm available in the chat also, so you can reply in the chat as well. Why I'm not able to? Okay guys, okay, so let's start it. We have some questions. If you have many more questions, you please let me know. If you have any doubt in the options, please let me know. If you have any change in the language, please let me know, right? So let's start with the questions of pharmacology. One question I got from a student, sir, the diuretics used for cerebral edema. So बच्चे, there is no doubt when they ask about the diuretics used for cerebral edema, without any doubt, the best diuretic for cerebral edema is mannitol. The best diuretic is mannitol. The second important diuretic is acetazolamide. Acetazolamide. These two diuretics are used. Mannitol is osmotic diuretic. Acetazolamide is carbonic anhydrase inhibitor. So definitely the mannitol is the most correct answer. Spironolactone is the drug used for cirrhotic edema. I will tell you about the other things also, which is the important thing for your coming exams as well. Spironolactone is a good drug for cirrhotic edema. Furosemide is the best drug for pulmonary edema. Pulmonary edema. So in pulmonary edema, best is furosemide. In edema due to renal cause, the best is furosemide. So in cardiac cause like pulmonary edema, so basically pulmonary edema is due to CHF, congestive heart failure. Renal cause edema, there is generalized edema or pedal edema. So mostly the patient is having the pedal edema. So in these type of patients, we use the furosemide. Thiazide is a good drug for hypertension. It is not a wonderful drug for edema. So out of these, definitely the mannitol is the correct answer without any doubt, right? So this is the first important question. The second question is if any doubt in the question, any option, then please let me know. The second question is hormone does not act through surface receptor. So I told you in the classes again and again ki sir, that in general pharmacology this is very important about the types or mechanism of the receptor. So does not act, the question is does not act through surface receptor. Surface means cell surface receptor. So this is important. Cell surface receptor does not act through cell surface means going intracellular. So basically they are asking ki which is out of these is intracellular mechanism. Intracellular mechanism, very frequently asked about the types of receptor. So which is out of these is intracellular receptor, you can see. So you can see in the thyroid it is nuclear mechanism. In the thyroid it is nuclear mechanism. In the insulin it is tyrosine kinase mechanism, enzymatic. In the growth hormone it is the Janus kinase, Janus kinase. Prolactin is also JAK. So basically these are enzymatic receptor. And remember the enzymatic receptor or ligand gated ion channels or GPCR, they all are cell surface receptor. Intracellular receptor out of these is the thyroid receptor. So intracellular, nuclear or cytoplasmic, cytosolic. So these are important for intracellular mechanism, mainly steroids, vitamin D, these are cytosol or cytoplasm. Thyroxine, that is nuclear, thyroxine is nuclear. So out of these the answer will be thyroid, because thyroxine is nuclear receptor. Next question, not an opioid, simple classification based question ki which is not an opioid. So out of these you can see oxycodone. Codone is the codeine derivative. Codeine derivative. So this is opioid receptor. This is opioid analog. Buterphenol, that is also opioid. Buterphenol is also opioid, acting on the kappa receptor. That is also good analgesic. L-fentanyl, fentanyl group of drug, that is also opioid. But lumefantrine is the anti-malarial drug. Lumefantrine is the anti-malarial drug, not the opioid. Not the opioid. Which one? Bhavna ji, which one is by the camp? Which one is by the camp? Camp is GPCR. Camp is GPCR. So tell me, out of these there is no GPCR. Right? There is no GPCR. Right? So GPCR is, we have alpha beta receptor, we have the muscarinic receptor, we have the histamine receptor, we have the serotonin receptor, we have opioid receptor, vasopressin receptor. So many receptors are there. Muscarinic receptor, right? So guys, so Bhavna ji, please read the classification we have discussed in the classes, right, properly. Not an opioid, so definitely out of these, which is not the opioid? No, growth hormone is Janus kinase. Janus kinase. It is Jackstat, just another kinase, Jackstat receptor. Jackstat receptor. Now comes to the next one. Tolerance, very important question, frequently asked and told you in the class also. Okay, sir, please read this line, very important. Tolerance is not produced in which of the following effect of opioid? Not produced. So where the tolerance is not seen. So I told you the three important point. Okay, sir, C, C and C. In these three there is no tolerance. First C, the most important C is the constipation. The most important is constipation. So if they ask you the single best answer, it would be constipation. But if there is no constipation in the choice, the second best answer will be constriction of pupil. Constriction of pupil, that is meiosis. The second best answer will be constriction of pupil, that is meiosis. And the third C is the convulsions. Third C is the convulsions. So out of the opioid action, there are three actions where there is no tolerance. So C, constipation, constriction of pupil and convulsions, there is no tolerance. Out of these, the correct answer will be meiosis, because in the respiratory depression there is tolerance, in the euphoria there is tolerance, in the sedation, all other actions there is tolerance except C, C and C. So this is the correct answer. Meiosis, there is no tolerance. So even if the patient is regularly using the drug, there will be no tolerance due to this, because tolerance decreases the effect. There is no tolerance in this action. Okay. Now the next is, which drug can be given in renal insufficiency? Which drug can be given in the renal insufficiency? I hope you remember I told you PMT. Out of the fluoroquinolones, all these are fluoroquinolones. All these are fluoroquinolones group of antibiotics. All these are fluoroquinolones group of antibiotic. Out of these antibiotic PMT, these are safe. No need of dose reduction. Safe in the renal failure patients. Safe in the renal failure patients. No need of dose reduction. PMT. What is PMT? P for pefloxacin. P for pefloxacin. Pefloxacin. M for moxifloxacin. M for moxifloxacin. And T for trovafloxacin. T for trova. These are the drugs where the dose reduction is not required. Out of these, commonly used in the market is moxifloxacin. So out of these, moxifloxacin is very important. And if moxifloxacin is not there in the option, or you can say the PMT is not there in option, then levofloxacin will be the answer. But out of these, which is the correct answer? It is the moxifloxacin. So PMT, which drug is safe or not safe? This is very important. So out of the fluoroquinolones, which is safe? The immediate management of methanol toxicity. In the methanol toxicity, immediate management. Remember, The first important is we use the best antidote. So what is the antidote for methanol toxicity? The antidote is fomepizole. For all the alcohol, the antidote is fomepizole, that is alcohol dehydrogenase enzyme inhibitor. The second important thing is in methanol poisoning we use the ethanol to basically what is the purpose? To use the same enzyme, because ethanol, methanol both are the substrate for same enzyme. What is the name of the enzyme? Alcohol dehydrogenase, which easily gets saturated by the ethanol. So that's why you can use the ethanol. Soda bicarb, very important, soda bicarb. If they ask you what is the drug decrease the risk of death in the poisoning, so one of them is soda bicarb, because acidosis is there. To treat the acidosis, soda bicarb. We use the folinic acid, that is very important to treat the toxicity. Folinic acid, or you can say the tetrahydrofolate, very important drug. Or then you can go for the dialysis if required. So these are needed for methanol toxicity. Out of these, anything in the option? So definitely the option ethanol is the correct answer. Ethanol is the correct answer in the immediate management of methanol toxicity. You can definitely use the ethanol. So ethanol will be the correct answer. Next question, what is the simple question? Antidote for paracetamol overdose. So in the paracetamol overdose, N-acetylcysteine is the antidote. Charcoal is not a specific antidote. Naloxone is the specific antidote for opioid. Penicillin is the chelator agent. So that can be used for some metals, right? That is for some metals. So out of these, the correct answer will be A, N-acetylcysteine. So that is simplest question. Everybody knows that. So we are not going in the detail. This is physiology question basically. Which of the following hormone has a hypoglycemic effect? So definitely out of these, the hypoglycemic effect is in with the insulin. Insulin will cause the hypoglycemia. Glucagon, thyroid growth hormone, these hormones will definitely increase the glucose production, because these are increasing the glucose, just opposite of insulin. So growth hormone increase glucose, thyroid hormone increase the glucose, because they are needed for growth. In the growth we need the glucose, and glucagon is the reverse, or you can say inverse of insulin hormone. So that is simply basically physiology. COX-2 inhibitors primarily block the production of COX-2. So बच्चे, we have COX-1 and we have the COX-2. If you block the COX-1 or COX-2, in the COX-1 it is primarily important for thromboxane A2. It is primarily important for thromboxane A2. COX-2 is primarily important for PG, prostaglandins. It is primarily important for prostaglandins. So PGI2. Right? So out of these, if you compare, then COX-2 is primarily for prostaglandin. That's why we say selective COX-2 inhibitors. Selective COX-2 inhibitors are the pure anti-inflammatory without any gastric side effects, right? But they have the more risk of MI. Why? Because thromboxane effect is not there. So that's why in the COX-2 inhibition, it is the prostaglandins. Thromboxane is due to COX-1. That is due to COX-1. Leukotriene is due to LOX enzyme, lipooxygenase enzyme. Lipooxygenase. Interleukin is not because of this COX enzyme. So in the COX we have the prostaglandins due to 2 and thromboxane due to 1. Liposomal amphotericin B. Liposomal amphotericin B, in short that is called as LAMB, is ineffective in treating which of the following condition? So liposomal amphotericin B is mainly antifungal drug. It is used for mucor or candida. It is drug of choice for candidiasis. Other than this, it is used for leishmaniasis, that is called as Kala Ajar. That is called as Kala Ajar, and it is the drug of choice for Kala Ajar as well. Now chlamydia. Chlamydia is one of the atypical microorganism. In chlamydia, the best drug is azithromycin. The best drug is azithromycin. Chlamydia is mainly causing pneumonia, but it can also cause trachoma and urethritis. So eyes, lungs and urethra. Eyes, lungs and urethra. Eyes, lungs and urethra, ELU. These three infections are there, and the best drug will be azithromycin for chlamydia. In chlamydia, azithro. In rickettsia, doxy. Don't forget this. Chlamydia, azithromycin. Pneumonia, chlamydia, azithromycin is the drug of choice. Lamb is safe. Amphotericin B, because amphotericin B is very risky. So it is mainly used for fungal infection like candidiasis, mucormycosis, cryptococcal meningitis. In all these conditions, we use the lamb, right? But in chlamydia, obviously, we will not use the lamb. Okay. Which of the following drug does not target purine or pyrimidine? Does not target purine or pyrimidine. So basically they are asking which is not a purine or pyrimidine analog. So out of these, which is not a purine or pyrimidine analog. So we have the three important antimetabolites. So these are basically antimetabolites. These are antimetabolites. So in antimetabolites, we have the three group: folate antagonist, purine antagonist, and pyrimidine antagonist. Out of these, methotrexate is the folate inhibitor, folate antagonist. Out of these, 5-fluorouracil is pyrimidine. Pyrimidine, thymine less death of the cell. Thymine remove, uracil is there. Pyrimidine analog, or you can say the pyrimidine inhibitor. And out of these, pentostatin is adenosine deaminase enzyme inhibitor. But both these drugs are purine. Both these drugs are purine antimetabolite. So pentostatin, cladribine, fludarabine, these are purine. Fluorouracil is pyrimidine, and methotrexate is folate. So what is the correct answer? It is the methotrexate, which is not the purine or pyrimidine. So this is simple question again from the classification of anti-cancer drug. In anti-cancer, I told you classification is the most important thing. In anti-cancer and antibiotics, mechanism, very important, mechanism based classification. Okay, metronidazole, you know, very important drug. It is anti-amoebic drug. It is anti-amoebic drug, not the anti-malarial. It is anti-amoebic drug, not the anti-malarial. So anti-amoebic, antibacterial. It is anti-amoebic, antibacterial. You know, it is the best drug for anaerobic infection. It is the best drug for anaerobic infections. In anaerobic infection, metronidazole is the best. It is safe with the alcohol? No, it is having the risk of disulfiram. It is having the risk of disulfiram reactions. Alcoholic patient, not safe. Increase action of warfarin? Yes, it increase the action of warfarin, because metronidazole suppress the CYP enzyme. It suppress the CYP2C9 enzyme, and that's why it inhibits the warfarin metabolism. It inhibits the warfarin metabolism. It inhibits the warfarin metabolism, and that's why it is increasing the action of warfarin. It increases the action of warfarin. It reduces the protein? No, it is not for protein. It is basically nitro-free radical DNA injuries. It is causing the DNA directly injuries. So with metronidazole, important antibiotic, it is suppressing the warfarin metabolism. That's why warfarin effect will be more due to metronidazole. So out of these, option B is definitely the correct answer. In TB, I told you every time you will get one or two questions from the TB drug. So you can see one question: anti-TB regimen having risk of color blindness and loss of vision. So color blindness, loss of vision due to anti-TB drug. So remember, E for ethambutol, E for eyes. E for ethambutol, E for eyes. Pyrazinamide, Z for joint. So you can remember the joint pain, right? Isoniazid, Niazid for neuro. Niazid for neuro. Streptomycin, you know, that is injectable. Nowadays we don't use, mainly nephrotoxic. Mainly nephrotoxic. So these are important. Out of this, rifampicin causing discoloration of the urine. So red orange urine due to rifampicin. So ethambutol, remember, E for eyes. So these side effects are due to ethambutol. Ethambutol. One more question from the TB drug. I told you newer TB drug. The newer TB drug, there are two important: bedaquiline, delaminid, pretomanid. So pretomanid or delaminid, the mechanism is same. These are used for resistant type of bacteria, MDR, XDR, TB. It is the drug which inhibits the mycolic acid synthesis of the bacterial cell wall. Mycolic acid, which is inhibiting the synthase, ATP synthase enzyme, that is bedaquiline. Very important drug, bedaquiline as well, which is a RNA polymerase inhibitor, rifampicin. All these are anti-tubercular drug. Rifampicin, protein synthesis inhibitor, is not there in the anti-tubercular. It is the drug which is inhibiting the mycolic acid synthesis, and this is approved for resistant TB. This is approved for resistant TB patient. Resistant TB patients. So this is bedaquiline. This pretomanid. Also we have the bedaquiline for this. One important drug approved in India recently is B-PAL-M regimen. So bedaquiline, pretomanid, then linezolid and moxifloxacin. Bedaquiline, pretomanid, linezolid and moxifloxacin, approved for resistant TB. All oral drugs, right? Shorter regimen. So pretomanid is important, that's why. Which of the following is true? Which of the following is true regarding muscle relaxants used in anesthesia? So there are two types of muscle relaxant. One is depolarizing like succinylcholine, and rest of them are non-depolarizing or competitive blockers like curare like drugs. Neostigmine is used for antidote for succinyl. Never. Neostigmine itself cholinergic drug. Cholinergic drugs cannot be used for succinylcholine because both are causing depolarization. Both are causing the depolarization of the receptor. So you cannot use the neostigmine for succinylcholine. Succinylcholine itself very short acting. It is metabolized immediately by the esterase enzyme. No need of any reversal. So neostigmine is used as antidote for non-depolarizing muscle relaxant, not for depolarizing. Succinylcholine is the only depolarizing muscle relaxant that is available for clinical use. Absolutely true. So we use the succinylcholine for clinical use. It is used for endotracheal intubation. Very short acting drug, metabolized immediately by the pseudocholinesterase enzyme in the plasma, and it is used for intubation. It is the best drug for intubation. The mechanism of action of train of 4 in depolarizing shows the fade mechanism. No, fade mechanism is seen in the again in this succinylcholine. So which is true regarding this, right? So this is about the succinylcholine. So depolarizing muscle relaxants, no. Succinylcholine is the only depolarizing that is clinically used. So this is succinylcholine. Why? Because of the esterase enzyme, and it is very short acting, and it is no need of any reversal. Now bupivacaine, what is not true regarding bupivacaine? Bupivacaine is one of the local anesthetic. I told you, if there is I before cane, that is amide. So it is amide. Yes, there is I before cane, so that is true. I before cane is amide, so that is true. The quick onset of action, yes, definitely bupivacaine is faster acting drug, longer, faster. Not used often in epidural due to poor effect on skeletal muscles. That is also true. That is also true. Then also used in ventricular arrhythmia. Never. It is most toxic. It is highly toxic in arrhythmia. It is highly toxic in arrhythmia. The only drug used in arrhythmia is lidocaine or lignocaine. Lidocaine or lignocaine is used for arrhythmia, but this bupivacaine itself having the high risk of arrhythmia, so we don't prefer bupivacaine for this. Lignocaine is used out of these. So it is poor effect on skeletal muscle, yes. Quick onset of action, yes. Hydrophilic amide, so I told you I before cane, that is amide, so that is A. So all A, B, C are true, but D is not true, so that is false. That is false. Which of these is a reason for rare use of ester local anesthetic in clinical use in infiltration anesthesia? Infiltration, so locally infiltrate, so you infiltrate locally. Short duration of action, one by one. So what is the reason for rare use of ester? Why ester is rarely used? Options are shorter duration of action, incomplete analgesia, chances of hypersensitivity, metabolism by plasma esterase enzyme. So remember, short out of these, with the ester local anesthesia, is it metabolized by plasma esterase enzyme? No. Local anesthetics are not metabolized by plasma esterase enzyme. These are muscle relaxants which are metabolized by the esterase enzyme, not the ester local anesthetic. Chances of hypersensitivity, yes, definitely the chances is there in the, see, when we give the infiltration, it is not commonly reaching to plasma. If it is not reaching to plasma, then definitely there will be no direct effect of esterase enzyme. Esterase enzyme is there in the plasma, so it is not metabolized by the plasma esterase in the infiltration, because directly infiltrate around the nerve, so not reaching to plasma. So this option is correct. Incomplete analgesia. So incomplete analgesia is no, it is no, again not correct. Why? Because when we infiltrate, it is reaching to nerve directly, and it will cause the analgesia effect. Short duration of action due to infiltration, no. In infiltration, it is not metabolized. You see the option, if it is not metabolized, so it is not short, it is the longer acting drug. So in the infiltration, it is longer, not metabolized by esterase, that's why it is longer. Analgesia is complete. Chances of hypersensitivity is definitely still there, because when you infiltrate, the reactions, skin reactions are possible, hypersensitivity is still possible. So out of these, if you see, option 3 is the absolutely correct reason why they are for this purpose, right? Local anesthetics. So now, which of these is used as a carrier? Very simple, used as a carrier for other anesthetic agents. So there is nitrous oxide, which is the drug used for this purpose, and you know nitrous oxide can be used as a carrier, or nitric oxide can be used as the sole agent for dental and obstetrics. In the dental and obstetrics, we can use the sole agent as well. Halothane, desflurane, ether, so these are volatile liquids. Nitrous oxide is the gas, it is the only gas available, rest of them are liquids, so they can be used alone, but nitrous oxide mostly not used alone, because it is not a complete anesthesia, it is a poor muscle relaxant, so mostly it is given as a carrier. So these are the questions which have been asked, recall based questions, so I'm not sure about all the options, but still we tried our best to give you the correct answer. So that's all from my side. Thank you guys, and the questions were not very tough, so please remember, this was the moderate type of paper. So that's all from my side in pharmacology. Thank you, bye bye, take care, good night, namaskar. Okay, we got one question from Fatima. All of the following are effective in neuropathic pain except pregabalin, carbamazepine, amitriptyline, duloxetine. Sir, answer is B, but won't be D. See बच्चे, in neuropathic pain only 3 drugs we prefer, only 3 drugs we use basically. In neuropathic pain we use the pregabalin, gabapentin, absolutely. Second, carbamazepine is for neuralgia, not for neuropathic pain, that is for neuralgia. Amitriptyline, that can be used for neuropathies. Duloxetine, that is SNRI, so that is used. So remember बच्चे, for neuropathic pain, the best drug is gabapentin, pregabalin. The best drug is gabapentin and pregabalin, that is best. But other drugs we use is the tricyclic antidepressants like amitriptyline. We use the SNRIs, like duloxetine. Other than this, one important drug we use the tramadol, because tramadol is having the dual property, it is opioid plus NRI, norepinephrine reuptake inhibitor. So that's why in this the answer will be carbamazepine. Okay, Drug administration to a 65-year-old with GFR 60 ml per minute, liver and biliary functions are normal. What should be the dose rate? Answer is 30 milligram per hour. Sir, how to solve this type of questions? So, bache, they have given you the GFR. Normally, we count the GFR 120 to 180. We count the GFR 120 to 180. So now, no. In dose rate, we have to see what is the basically dose rate in the normal people. Then only you can adjust with the GFR. Right? This is incomplete question. So you have to see in normal GFR, this is the rate. If the GFR is decreased, then what will be the rate? Right? So you have to give the correct question first. So drug administration directly, if you are saying ki 30 milligram per hour, so why the answer is 30 milligram per hour? If you don't know the exact dose, first you need to know the exact dose, then you have to adjust the dose as per GFR, right? Okay, so in the group you can discuss the all these questions. Tonight I will be free, so I will be trying to solve all your doubts in the groups as well. So in our NEET MDS group, definitely we can discuss all the doubts. Tonight definitely I will reply, because before 4-5 days I was very busy in the classes. So tonight I will definitely give all the doubts answers.